Well, thank you very much. And we'll just get started. There is only one polling question, and it comes towards the end. Here's our case, an 83-year-old woman with a history of hypertension, diabetes, chronic renal insufficiency, and a history of a GI bleed, presents with palpitation and is noted to be in atrial fibrillation. She has a transthoracic echo, which shows normal LV size and function. There's aortic sclerosis and mitral annular calcification, but normal valve function, so her atrial fibrillation is not valvular. Her TSH is normal, and she's otherwise been well. How can you approach reducing her risk of adverse events? So that's what we're going to spend the time talking about, and you can think to yourself, what adverse events do you suppose he's talking about? Well, primarily, when we're talking about adverse events with atrial fibrillation, although it's associated with a lot of other outcomes, is stroke risk and stroke risk reduction. So you all have heard over the years of both the CHADS-2 and the CHADS-2 VASC score. The CHADS-2 VASC score is the preferred method for risk stratification for thromboembolism currently. The CHADS-2 VASC score was developed, in a sense, to better discriminate at lower levels of risk. So some of our patients have very high risk, and they'd be high risk regardless of which scoring system was used. But at the lower levels of the CHADS-2 risk score, the CHADS-2 VASC will better discriminate and recategorize folks into elevated risk. And as a general rule, a CHADS-2 VASC score of 2 or greater is an indication for systemic anticoagulation. And you guys have, while I've been droning on, looked at all of the components, if you don't already know them: heart failure, hypertension, age, diabetes, prior thromboembolism, the presence of vascular disease, female gender. And you can see on the right-hand side the adjusted stroke rate in percent per year according to each of those combination scores or additive scores. So the flip side of anticoagulation, of course, is bleeding. Bleeding can be nuisance. It can be gum bleeding from brushing teeth, can be easy bruising from bumping your arm when you walk into a door by accident. But it can also be life-threatening. It can be life-threatening intracranial hemorrhage. It can have GI bleeding, as our patient did. We didn't specify how severe that bleeding was. It can be hemorrhoidal bleeding that can usually be more nuisance, or can be massive GI bleeding requiring red cell transfusion and ICU and resuscitation and so forth. There have been a number of bleeding risk scoring systems or risk stratification schemes. These are 3 of them: atria, has-bled, and hemorrhages. You can see all the various components of the scoring system. They include things like renal or hepatic disease, alcohol abuse, age, high blood pressure, and a lot of these things are actually things that also increase risk for thromboembolism. So increasing age, prior stroke, are all things that, and high blood pressure are all things that increase risk of stroke, and they also increase risk of bleeding. The has-bled score is probably the most common and most well-known of these, but all have been studied. So looking at has-bled according to number of combined positives or points, you can see that the risk of bleed per 100 patient years is listed on the right-hand column. So, obviously the higher the number of risk factors, the more risk of bleeding there is. Here is a similar table for the hemorrhages risk scoring system, a little bit more cumbersome, more factors, with the risks for bleeds for 100 patient years on the right. So here's our polling question, thinking about our 83-year-old woman and how to best balance stroke risk reduction with her bleeding risk. So choice A is calculate her CHADS-2 VASC score and the has-bled risk score. And if the stroke risk is greater than the bleeding risk, you should prescribe anticoagulation. If the stroke risk is less than the bleeding risk, you should not prescribe anticoagulation. Second choice is similar with the CHADS-2 VASc score, but in this case the hemorrhages risk score, which is a little bit more cumbersome but does encompass more risk factors in their analysis and in their schema. Choice C is calculate the CHADS-2 VASc score, and if it's greater than or equal to, it should say 2, greater than or equal to 2, prescribe anticoagulation. But if there's a history of bleeding, reduce the INR goal to 1.5 to 2 as opposed to 2 to 3. Choice D is calculate the CHADS-2 VASc score, and if it's greater than 2 and the patient has a history of bleeding, as our patient does, prescribe aspirin and Plavix and not systemic anticoagulation. So I don't know how rapidly the polling results will show, but punch in your choice.
The results.
Okay, great. So thank you for participating, and I apologize. So we had about 45% choosing A, and I apologize that that this is a little bit of a trick question, because although you're gonna you're trained to choose the best answer, and so that probably is the best answer, but it's not the best answer if it was like a free response right in your own answer. And that is because our bleeding risk scores have really relatively poor predictive accuracy. So although they may be helpful, and this is from the ACC/AHA guidelines on atrial fibrillation from 2014, the reference is there, and there's a more complete reference list at the end of the presentation. Although they may be helpful in defining patients at elevated bleeding risk, their clinical utility is insufficient for use as evidence for the recommendations in this guideline. Now, I will say that has bled, as opposed to atrial hemorrhages, two other common scoring systems, is probably better and discriminates better. And on the has bled risk scoring system, a score of greater than or equal to 3 indicates potentially high risk for bleeding and may require closer observation of the patient for adverse risk, closer monitoring of INRs, or differential dose selections of anticoagulants or aspirin. So if a patient, for example, has additional indications for aspirin, you may choose to omit that if the patient has increased bleeding risk based on has bled. But although it's tempting to just pull up both scoring systems and say, well, this risk is a little bit higher, so I'm going to go with that. So if the stroke risk is higher, I'm going to go with anticoagulation. If the bleeding risk is higher, then I won't. So what should you do in approaching patients that have both combined risks? And everybody really has combined risk of both bleeding and thromboembolism when they have atrial fibrillation. So this is really a true opportunity to practice shared decision making with your patients. It's appropriate to calculate the risks with patients, particularly for those who are numerically oriented, and say, you are at significantly increased risk for stroke, and so we're going to talk about a blood thinner, anticoagulation, and I haven't talked about choices there so much in this talk. And say, but we do know, based on these other risk factors, that you do have an increased risk for bleeding as well, and talk to them about their thoughts about those things. Some patients have had relatives or friends that have been on anticoagulation and had bleeding problems, and they'll up front say, I'm never going to take one of those things. And that's a choice that some people will make. On the other hand, some people will say, my best friend just had a big stroke, and that's something that I want to avoid at all costs. And I know that there is an increased risk of bleeding, but can we talk about ways to reduce that risk? But I really want to avoid having a stroke because that was devastating for that significant person in their life. And then the other thing is that to remember that although these are important decisions, these are decisions that can change over time. So I try to tell patients, this is the first time you've been thinking about this, if it is, and these are some of the issues, and we should schedule another appointment to come in and talk more, let you think about questions, talk to your family and friends about it, and we can come to a final decision or a not final decision about whether or not to start anticoagulation at that next visit. And then that can be revisited over time as well. For most patients, it's not critical that a decision be made right at the time of diagnosis, but rather that they can take some time and think about those issues. With regard to GI bleeds, ulcer-related GI bleeding recurrences have been reduced through the detection and treatment of H. pylori infection. And treated patients, triple therapy treated patients, are at no greater risk of rebleeding, so that's important. NSAID use reduction can reduce the risk of GI bleeding, as can potentially PPIs and coating agents. So for patients with GI bleed, you can help modify their risk for bleeding there. And then I just wanted to briefly mention that there are some emerging other therapies to reduce stroke risk reduction, although their place in sort of the armamentarium is not yet fully worked out. And these are left atrial appendage closure devices, including plugs and a lariat device that sort of ties off the appendage. The European Society of Cardiology has a weak recommendations for use for those with contraindications to oral anticoagulation. The FDA actually has approved the Watchman device for those who are eligible for oral anticoagulation, but have other indications for non-pharmacologic therapy. In other words, they have some things in their life that would make it less appealing to be on anticoagulation if they have a lifestyle that is likely to make checking INRs untenable. They have labile INRs, or they engage in higher risk physical activities. And then the ACC/AHA guidelines actually don't address device closure. Those are 2014, and so there's a lot more emerging data. But they have a weak recommendation for excising the left atrial appendage at the time of cardiac surgery to reduce the risk. And the reason there's such a focus on left atrial appendage is because that's the most common reason, or the most common place for thrombus to form in patients with atrial fibrillation. So these are a couple references: the ACC/AHA guidelines and the European Society of Cardiology guidelines for the management of atrial fibrillation for those who are interested, and they provide a lot of other, a good review of evidence. So I'm happy to take any questions that folks in the audience have.